All right, good afternoon, everyone, and thanks for all of you who are here who have showed up today on this beautiful summer day in Rochester for the Romano Grand Rounds. I'm Rob Weissman. I'm the Clinical Operations Director for the Community Division, of which the program you're going to hear about operates within. A few housekeeping agenda items that we want to make sure is that please, if you have questions, those of you both in-house or online, to post them on the Q&A portion of the procedure here. And afterward, we will have questions. Please don't put those questions into chat, but into the Q&A portion of the session. Moving on, I'm really excited to announce and be the moderator today for a program that I think is so vital and been a long time coming for our community division in particular, and I think our community services in general. We're going to be hearing about community ties, expanding the horizons of outpatient mental health care. Community ties, you will hear a whole lot of information about what it is, how to access it, how it evolved. But more importantly for me, having been in the community division now for probably close to 30 years, which is scary, we have been thinking about something like this for that long of a time, and now we're realizing it. And this group of individuals here that will talk about it and help generate this important program, I think you will find very interesting. I want to acknowledge a couple people behind the scenes who were very instrumental in this, beyond the individuals here that you'll hear from. Maria Romano, who is here up front. Maria has done excellent work here, both with vision and implementation. All of our administrators at Strong Ties in our community division and elsewhere who have made this idea a reality. This is also, I think, a very appropriate presentation for the John Romano clinical rounds, as John Romano himself was involved in unique and new interventions for community care. And there is nothing greater than this kind of program that you'll hear about today to help bridge in what I call a bi-directional clinical program to improve the continuum of care amongst all of our programs to serve our individuals in the community. And I think John Romano would have been proud of what we're going to hear about today. So I will not take any more time from this great group of presenters here, and I look forward to hearing it myself. So please.
Thanks, Dr. Weissman. I know all of us are excited to be here and talk about these exciting developments as well. I've been attending these grand rounds for 8 years now, so I guess I'm due to be on this side of the podium or on this side of the screen. And it's exciting to be with my team members and colleagues, Livia, Damiano, and Pam Geil, to share the exciting next steps in the community division. Unfortunately, our team nurse, Sarah Bubel-Thompson, is not able to be with us here today, but I know she's watching and supporting us. Of course, every grand rounds needs learning objectives, and these are ours. By the end of this presentation, I hope you'll be able to understand the many challenges to providing care to patients with severe and persistent mental illness, both in clinic and in higher level of care with the ACT teams. You'll hear about our new Community Ties team and how this intervention meets some of the gaps and needs in the department. And you'll understand the process to refer patients to us for care. None of us has anything to disclose. Looking ahead in this presentation, we will talk about the existing services we have in the community division. We'll talk about gaps and needs, and then review in detail the implementation of our new Community Ties intervention to address these needs. I'll then step away and let Livia and Pam share cases, next steps, and the process to refer patients. So Strong Ties is our department's main outpatient clinic for patients with severe and persistent mental illness, or SPMI. When we say SPMI, we are referring primarily to patients with diagnoses of schizophrenia, schizoaffective disorder, bipolar disorder, and severe or psychotic depression. We do treat patients with comorbid personality and substance use disorders, though primary disorders in those domains are typically referred to more appropriate clinics. Strong Ties is designated as a CCBHC, or Certified Community Behavioral Health Clinic, which means that we directly provide comprehensive mental health services to our patients. And we'll talk more shortly about just how comprehensive those services are. Strong Ties was established way back in 1988. And we actually still have a couple clinicians there that have been there since the beginning. Thinking of Dr. Lamberti and Heather Muxworthy, who have seen the clinic grow and evolve over the years. When Strong Ties started, they had an enrollment of about 300 patients, and now it's grown to nearly 2,000. And over time, the clinic has grown to meet the needs of our patients, our department, and our community. And our Community Ties team is the next step in that evolution. So for an overview of current clinic numbers at Strong Ties, at our main Strong Ties clinic, we have 15 primary therapists and are currently recruiting for 2 full-time therapy vacancies. We have 3 therapy supervisors. We have 9 psychiatrists and psychiatric nurse practitioners, and we host 3rd and 4th year psychiatry residents. The young adult program, a bit smaller. We have 3 primary therapists with 1 vacancy and 1 team lead vacancy. We have 3 psychiatric providers, and we host 3rd year psychiatry residents. We get a lot done at Strong Ties. And you'll see here, last year in 2024, between Strong Ties and the young adult program, we delivered over 35,000 units of service to more than 2,000 different patients. It's truly a remarkable volume of service. I mentioned before the comprehensive nature of the services we have at Strong Ties, and I've listed those here. We've talked about medication management from psychiatrists, nurse practitioners, and psychiatry residents. We have therapists trained in a variety of evidence-based interventions, including this alphabet soup of modalities here: DBT, cognitive processing therapy, EMDR, CBT for insomnia, prolonged exposure, and a different act, acceptance and commitment therapy. We have a number of groups: CBT, DBT, peer-led groups, multifamily group that we're excited to have return after a couple-year hiatus, as well as health promotion groups like diabetes management. We have a full array of crisis services. We have marriage and family therapy services. We have peer support services for both patients and their families. We are lucky to have embedded substance use disorder treatment, and we have psychiatric rehabilitation, focusing on vocational and educational goals of our patients, which I think speaks to the recovery-oriented approach of everyone in the clinic. We're all there to work with patients on shared goals, focusing on not just symptom reduction, but also functioning and creating meaning. Strong Ties Clinic exists within the larger Brighton Health Center, which is truly a one-stop shop for our patients. We have our clinical care, which I've just described. We also have our MIPS, outpatient medicine and psychiatry, primary care for our patients at Strong Ties. We are very lucky to be able to work closely with them for integrated mental and physical health care. We have Strong Ties Pharmacy on site, which is a fantastic resource for patients and clinicians alike. I really come to appreciate how readily available our pharmacists are for consultation, and it seems like there's no problem they can't solve for us. We have lab services, which is another invaluable resource for our patients, allowing them to get labs for health maintenance, medication levels, and overall wellness. We have our strong recovery, which is more intensive outpatient chemical dependency treatment. We have care management. We have the Intercept program for prodromal psychosis and early intervention. We have adult partial, and we have the mobile crisis team. So really, our center exists to provide integrated care to meet the complex needs of our patients. And we have an impressive array of services. However, there's challenges to providing care to this population. Looking at the numbers from last year, 2024, we had 42,491 scheduled encounters. 63% were completed, 24% were canceled, and 13% were marked as no-shows. So we have 37% of our services that were unable to be delivered. And this is a problematic number and one that has remained relatively consistent over years. And it highlights that despite our best efforts, there are still challenges and gaps to providing treatment to this population. So what are some of the reasons for difficulties with patient engagement? Well, it's multifactorial, with both illness and psychosocial factors contributing. Most of our patients have recurring symptoms of a psychotic disorder, which, as we know, can present with positive and negative symptoms. I have these listed here, and it's easy to imagine how experiences of thought disorganization and paranoia could make it difficult for someone to both get to the clinic and to establish meaningful relationships with their treatment providers. Perhaps more challenging are negative symptoms. Executive dysfunction makes it hard to organize one's day and plan for appointments and structure life around a lot of kind of intensive care. And nosoagnosia, or lack of insight, is another big problem. It's hard for patients to be motivated to come regularly to appointments when we don't have a shared understanding of a problem. And then low motivation and initiative I have listed here, not as judgment or reflection of character, but really as a symptom of illness that we need to consider and address. Patients also struggle with physical limitations and childcare responsibilities. These are issues we'll hear more about in our case presentations. And finally, there's stigma and shame. Despite our efforts to maintain a welcoming environment, our lobby and formal treatment settings in general may be intimidating to some patients and serve as distressing reminders of illness. So there's a sizable portion of our Strong Ties Clinic patients that have a need for services but are not able to fully access them due to both illness-related factors and psychosocial issues. Given this challenge, how do we better meet the needs of these patients? How can we improve attendance and patient satisfaction with treatment? How do we reduce hospitalizations? Can we provide a higher level of care to these patients who are experiencing difficulty engaging at the clinic level? And finally, how do we think about how these issues affect clinicians? Our primary focus is on patient needs, but it can be quite demoralizing to dedicate efforts to providing care to patients that are not able to show up for much needed treatment. So now we have a better understanding of the need for a step up in care for certain patients in clinic that aren't able to reliably engage. But we also have patients with challenges stepping down in their level of care. Assertive community treatment, or ACT, is the highest level of outpatient care for individuals with SPMI. Strong Ties is home to 3 assertive community treatment teams. I have them listed here. Strong Ties Act was the first ACT team in Monroe County, established back in 1997. There's a lot of regulations around ACT teams, and it involves a lot of intensive support for patients with a high staff-to-patient ratio. Project ACT was developed alongside the Office of Mental Health as a first attempt at providing forensically oriented ACT for justice-involved patients. And our new forensic ACT team is one of 4 new ACT teams in the state that have been rolled out with a new model treating patients recently released from incarceration or otherwise having substantial involvement with the justice system. It has a higher staff-to-patient ratio than even traditional ACT, and there is more intensive staff training and assessment on preventing criminal recidivism. But there's a problem with ACT. ACT is intended to be a time-limited or transitional program. However, many patients that have required this level of care struggle to drop down to clinic level care in having a reduced intensity of care. You see here that most of our ACT patients are in this level for 5 years, and about half of them are, I would say, long-term. They've achieved relative psychiatric stability, but are not able to step down in care, still need intensive psychosocial support. There's also a persistent and growing need for ACT level of care in the community. The number of ACT slots in Monroe County have increased significantly in the last 5 years. And despite that, we still have 20 patients in the county on the wait list. So our ACT teams work really hard and do exceptional work to prepare these patients for transition down to clinic. However, many still struggle to attend appointments at specific dates and times. Despite stabilizing acute illness, a lot of the barriers that led to the need for ACT level of care initially are still present. It's a big step down in care, going from ACT with generally about 2 contacts a week to at most 1 contact a week in clinic, and oftentimes less than that. We all know that stability in serious mental illness is tenuous, and the things that tend to be disruptive to our patients are sources of stress. And this step down in treatment can unfortunately present additional stressors for patients and put them at risk for decompensation. So recognizing the needs of both Strong Ties Clinic and the ACT teams, what if we can provide an intermediate level of care, allowing patients to more gradually step down from ACT level services and transition to clinic-based services, while simultaneously allowing a step up in care for clinic patients to reduce their barriers to treatment. With these services for all of these patients being provided in the community, in their homes or other preferred location, as opposed to in clinic. Community Ties was envisioned as this intermediate level of care, allowing patients to more gradually step down from ACT, as well as allowing a higher level of care for these clinic patients who don't quite require ACT level of care. This novel level of care was designed to be more flexible than clinic or ACT, with fewer requirements related to visit frequency and scheduling. You'll notice the relationship between Community Ties and Strong Ties Clinic is bidirectional. The goal for most of these patients is to ultimately step down to clinic, although we recognize there will be a subset of patients who will likely require community-based services moving forward. So Community Ties is, as I mentioned, community-based or in-home treatment for individuals with severe and persistent mental illness. We offer medication management, psychotherapy. We have more intensive nursing interventions than we can offer in the clinic. We work closely with our health home care managers and work to link patients to other appropriate services. And again, this is intended to be transitional, working to eventually get patients to a point where they can engage in clinic. Here we compare some of the similarities and differences of ACT and community ties. The big thing to note is the contact frequency, with at least 6 contacts a month for ACT and less than 4, up to 4 for community ties. And most of our patients have about 2, maybe 3 contacts a month. Some of the services that ACT offers directly, such as chemical dependency treatment and care management, are services that we can link patients to in the clinic if we're not providing them directly. It's important to know that all patients stepping down from ACT are eligible for Health Home Plus level of care management. Our team formed in October of 2023, and we began enrolling patients the following month. So far, we've enrolled 12 patients, 3 of whom have stepped up from ACT level of care, and 9 of whom have stepped down from ACT. 9 have stepped up from clinic. The diagnoses are listed here, and they're what you would expect for our population of patients with SPMI. More than half of our patients are currently receiving long-acting injectable antipsychotic medication. We're familiar with the critical role that LAIs play in maintaining stability for many patients. They reduce hospitalizations, they reduce ambiguity in medication adherence, and they reduce reminders of illness and treatment, which is important for many patients. We so far have had 1 patient successfully complete the transition from our team back down to clinic. Our primary team is small, but the whole team is quite large. It takes a real team effort, and I think this is a testament to how important this intervention is to everyone in the community division, in all disciplines, social work, nursing, ACT, and we are extremely appreciative of everyone's contributions to this endeavor to make it possible. We'll talk about each of our roles, and I'm going to describe mine first just so that I can step aside and let Livia and Pam speak. I have my responsibilities listed here. There's only so many ways you can say psychiatrist. Medication management is a small but important piece of recovery, and I and all of our clinicians at Strong Ties work to take a recovery-oriented approach, focusing on patient goals and building shared understandings of treatment. As a clinician, I've appreciated the flexibility afforded by this model. It's less regimented with respect to timing and scheduling, allowing for us to be truly patient-centered in our care delivery.
All right. Thanks, Dr. Small. And I just want to take a second to thank everybody for joining us to listen and learn more about community ties. And we're really excited to, share some information about this new team that we've been able to develop. So I'm Livia Damiano. I'm the crisis team leader and community ties team leader at Strong Ties. In short, my role as the crisis team leader at Strong Ties entails overseeing Strong Ties crisis services within the clinic and working with our 2 additional crisis therapists. I'm responsible for triaging crisis therapy requests and coordinating crisis services for our patients. Our crisis team can facilitate in-clinic services, but they also can facilitate community-based services. Through wearing this new hat of Community Ties team lead, we've really been able to use our crisis services as another means of coordination for Community Ties patients. For example, providers might request a community visit for a patient who's not engaging, not responding to outreach, and just historically has struggled to engage. I can implement a community visit based on a crisis request and discuss the community ties team and work with the patient to identify whether or not community ties would be a better option for their ongoing psychiatric care to help re-engage them. The collaboration with treatment teams within my crisis role has also helped integrate our community ties services and coordination. Within my community ties role, I function as the primary therapist and team lead. This meaning, I'm responsible for caseload management, referral triaging and coordination, visit scheduling, assessing visit frequency based on clinical indication and patient need. I provide direct clinical services such as psychotherapy, crisis intervention, risk assessments, symptom management, and diagnostic evaluations. I also am often collaborating with patients' families, health home care managers, social supports, and other community members to coordinate overall care. I've really been able to work with patients through a hybrid model of care, meaning that community visits and clinic visits are offered and implemented. And we've really found that this increases patients' comfortability with coming into clinic and also allows us to be able to assess their readiness to make that transition back to in-clinic care. The ability to really implement, a community clinic hybrid model we have found is, can really lead to positive outcomes for our patients to help re-engage them. All right. So as Dr. Small mentioned, unfortunately, Sarah was unable to be here with us today, so I'm going to do my best to kind of capture her role as our team RN. Within Strong Ties Clinic, Sarah functions as our nurse care manager, meaning that she holds an individual caseload where she works with patients on engagement, health monitoring, safety assessments, education, and coordination with medical agencies. She can assist with medication or medical care needs, such as pharmacy changes, medication side effects, med packing, and medication delivery. Within her community ties role, Sarah functions as an intermediate role between a clinic RN and an ACT RN. Sarah is responsible for LAI administration and monitoring, health education and monitoring, such as assisting with diabetic management, medication side effects, and so on. Providing annual primary care screens required by CCBHC guidelines, linking patients to primary care at MIPS, and URMC specialists and outside care providers as well. Sarah can deliver medications to our patients, is able to check medications, and she's also able to reconcile medications as well. Sarah's really been able to work with patients both on the community level and clinic level. As I mentioned earlier, we do have times where patients are coming into the clinic just within that hybrid model, and Sarah still is providing their LAI and other services when they're coming into the clinic just to help keep the consistency and continue building rapport. All right, so we wanted to take a few minutes just to go through a few of the patients that we have been working with, just to demonstrate the positive outcomes that we have seen. So for case one, she is a 51-year-old female diagnosed with chronic paranoid schizophrenia. She lives independently with her adult daughter and is a big fan of daytime soap operas. She was enrolled in Strong Ties Clinic in 2011 and historically had difficulty with engagement due to experiencing a frontal lobe stroke in 2017, followed by mobility complications requiring the use of a wheelchair. These complications made her ability to come into the clinic difficult and led to her being unable to receive her LAI consistently, which would then lead to significant psychiatric decompensation, often requiring hospitalization. Prior to her transfer to Community Ties, she had about 7 psychiatric hospitalizations, with her most recent admission being in October of 2023 and November of 2023. In 2023, she only attended about 22% of injection appointments and 25% of visits with her treatment team. Since her enrollment with Community Ties in January of 2024, she's engaged in about 86% of her LAI visits and 88% of treatment team visits with no psychiatric hospitalizations to date. All right, so case 2 is an African-American male in his late 20s who's a father to a son in grade school and enjoys traveling. He lives independently through an East House supported apartment and has been followed by Strong Ties since 2017 for a diagnosis of schizophrenia with predominant disorganized symptoms. He has had about 1 psychiatric admission in the summer of 2022 for psychosis and has been followed by AOT. Prior to his transition to Community Ties, the 9 months prior, he attended about 45% of scheduled provider appointments and attended about 65% of LAI appointments. His identifiable barriers include disorganization, difficulty with planning and coordination. Since his enrollment in Community Ties of March 2024, he has participated in 91% of provider visits and 86% of LAI visits, with no psychiatric hospitalizations. He's now set to graduate AOT in February of 2025, so next month. Okay. So our next case is a 30-year-old African-American female with a diagnosis of bipolar I disorder. She's a mother of 3 young children and is looking forward to reaching her goal of attending cosmetology school. She's enrolled in Strong Ties Clinic in 2022. In her 2022 enrollment, she had difficulty attending appointments with providers and attending appointments to receive her LAI. Despite being followed by AOT, mental health court, and CPS, this patient would note that her primary barrier in treatment engagement was due to lack of child care support for her 3 young children. Prior to her enrollment with Community Ties, she had about 4 psychiatric hospitalizations, and her most recent admission was October of 2022. In 2023, she attended about 67% of LAI appointments and 48% of provider appointments. Since her enrollment in Community Ties in November of 2023, she engaged in 84% of LAI appointments, 75% of provider visits, completed Helio Health inpatient chemical dependency treatment, and was engaged in Strong Ties embedded CD services. She was really demonstrating a significant improvement in her engagement after participating in like a hybrid treatment model where she would come into the clinic to meet with me for therapy, but we also were still able to go out into the community as needed. After a stretch of time of her demonstrating the improvement in attending in-clinic appointments, she was officially transitioned back to clinic in September of 2024. Since the transition back to clinic, she's attended 100% of her LAI appointments and 89% of scheduled provider visits. Her CPS case was closed and she's set to graduate AOT this month. All right, so our 4th case was a transfer from ACT, who's a white male in his 30s. He lives independently in the community and enjoys collecting instruments and Star Wars memorabilia. He has a significant history of psychiatric hospitalizations related to his diagnosis of schizoaffective disorder. He was followed by ACT since October of 2018 until May of 2021. In May of 2021, he was transitioned to Strong Ties Clinic, and he was psychiatrically hospitalized within 2 months after transitioning. He had difficulty attending appointments and missed many LAI appointments. He was then transitioned back to ACT in August of 2021 due to an unsuccessful episode of care in clinic. This patient was then enrolled in Community Ties in December of 2023 due to no longer requiring ACT level of care, frustration with the frequency of ACT contacts, and continued resistance to engaging in clinic care. Since his engagement in Community Ties, he's participated in 91% of scheduled provider visits and has received 80% of LAIs on time, and all late LAIs were administered within 1 week. He meets with us about every 2 weeks and has noticed that the visit frequency is very beneficial to him. This patient has benefited significantly from working with Sarah, our team RN, as she has spent a significant amount of time providing DM2 education and providing supplies to him. She's been active in coordinating with his PCPs through MIPS and his endocrinologist. She's also provided a significant amount of psychoeducation and assistance with diabetic management. Okay. So in thinking about future directions, our primary goal is to continue to utilize a person-centered approach to ensure that we can meet the differentiated needs of each of our patients, and really doing this through a flexible hybrid model of care. We are seeking to continually improve attendance, adherence, along with patient satisfaction and treatment comfortability. Through improved engagement, we hope to continuously reduce psychiatric hospitalizations, no-show rates, and non-adherence. As Dr. Small mentioned earlier, we also hope to see an improved clinician morale rate and reduce clinician burnout rate, as it can be very difficult to provide clinic-based services to patients who are unable to engage in treatment in a meaningful way. When thinking about team expansion, we're looking to increase community time for each team member and implement new positions. We currently have a plan to add an additional CASAC 2 position to join our team, which will aid our ability in being able to really support our ACT teams and taking on more of these long-term patients so that our ACT teams are able to enroll new individuals who are really in need of that extra layer of support. In conclusion, we really just hope to continue to identify patient needs within our department and our community and be able to provide flexible patient-centered care through a community-based and hybrid approach. We're really excited about the impact this team can have on our patients and our community. And again, thank you for coming out today and learning more about community ties. And I'm going to pass it over to Pam, who's going to talk a little bit about the referral process.
Hi again, thank you everyone for coming. So of course, we are working on trying to really expand this service beyond just what we're doing within the clinic structure itself. I really want to thank Dr. Small, Livia, and Sarah for the outstanding work that they have done with this team, their ability to be flexible, creative, patient-centered, as you can hear. They get to know the people that they're working with, and the unique things that make them individuals outside of an illness. And I'm excited to think about our ability to expand this beyond just Strong Ties and the greater URMC network. I want to talk just for a minute about Strong Ties enrollment criteria. Within community ties, we still will need to make sure that individuals meet the diagnostic and age criteria for our team. So typically, patients enrolled at Strong Ties are going to be 18 years or older. We do treat down to the age of 15. That is typically in our Intercept program. Clinic will begin taking patients at 16 or 17 if that's appropriate, and we're able to offer that as well in the future with community ties. But what you will typically find is those patients are 18 and over. For community ties, they do need to reside within Monroe County. They do need to have a serious and persistent mental illness diagnosis. As Dr. Small mentioned earlier, that's typically schizophrenia, schizoaffective disorder, bipolar 1, major depression with psychosis. We would want them to be in agreement with the plan to engage with the community ties team. We cannot force community-based care on them, but as you can see, there are tremendous benefits to delivering that care in the community. These patients will typically have barriers to engaging in care. We've discussed that along the way. A lot of our folks have had multiple engagement attempts at Strong Ties. We open an episode of care, they somehow get lost to contact, and overall for their health and wellness, it's just not a good model of care. So community ties will really be able to bridge that gap. With the Community Ties team, obviously we are going to take co-occurring disorders. Substance use care is going to be, as Livia mentioned, kind of our next expansion that we would like to see for our team member. What are the exclusion criteria for both Strong Ties and the Community Ties team? Individuals who have a primary personality disorder, primary substance use disorder, primary developmental, autism spectrum disorder, organic brain disorder, or TBIs. Those individuals typically will do better in other programs within our community. So if you're looking to refer to our new Community Ties team, I want to say we're excited to really expand. We're hoping to see an increase in referrals as we move forward today. And we're trying to really keep the ability to refer to the Community Ties team consistent with the model of referrals that occur right now for Strong Ties Clinic. Our BSW currently utilizes our priority access pager for individuals being referred from our acute services, CPEP, mobile crisis team, the inpatient psychiatric units, and adult partial hospitalization program. What we would ask is that if we have 48 hours notice, when you contact us through the priority access pager, we will be able to review the referral. Maria and I will be managing the triage from those acute service referrals and trying to make a determination about whether we can enroll this patient within Community Ties. We would love to hear your recommendations. If you believe that this is a great fit for our team, please mention that when you make that priority access referral. However, we recognize as well that not all places can have the ability to give us 48 hours notice. We're going to have calls from CPEP, from inpatient who has a last minute discharge, and from mobile crisis team who really just can't wait for an appointment, and we understand that. What we will do is if they meet our clinic admission criteria, we will offer a priority access appointment just as we do now. If you note that this is an individual who you think would be appropriate for Community Ties, we will do the intake and our clinic team will work with the Community Ties team to ensure that transition. If that patient does not make it in to that clinic intake, the clinic therapist will be doing the outreach to offer a Community Ties appointment, again, if that patient is appropriate for our Community Ties team. For referrals from URMC programs that are not using the priority access pager, those individuals are typically right now referred to Strong Ties Clinic through our work queue. We would ask again that you continue to use that referral process through the work queue to send a referral. You can note on there that you would like this patient considered for the Community Ties team, and our intake and access coordinator will send that information along to Maria and I for review. And if appropriate, we will schedule right away with the Community Ties team. Given this is very new for us, obviously we will be looking to listen to feedback that we have from people who are referring to us, what is working, what is not, assessing with the team, and making any changes as we go along. I think our hope is certainly down the road to expand even greater. be able to take referrals directly from other community sources, from patients themselves, from other providers out in the community, again, as long as they meet our diagnostic criteria for strong ties. So with that, I'm going to hand it over to individuals for any questions.
Thanks, Pam, for closing and all of our panel members here for a very important presentation about an important program that's bridging the gap, what I feel is a long jump from intensive services like ACT and FACT programs into our clinic. And this, I believe, if we've even seen in the short term, is showing some impact on this concern and these challenges. Just a reminder for those of you online, if you have questions, put them in the Q&A portion of your interface. Any of you in-house, just walk up to the mic if you have thoughts, questions. I've created a few myself just in case no one is bold enough to step up. Oh, right, there we go.
Hi.
Can you announce your name, please?
I'm Katie. I work in adult inpatient psych on 39000. For patients that are already connected with strong ties that might need more of the community ties level of care, what's the process for that?
So for the patients who are already enrolled, I would suggest that the inpatient treatment team work with the clinic treatment team to discuss your recommendations for community ties. We have an internal referral process, so if the patient is already linked to strong ties, our clinic team can do that referral directly to the community ties team.
Dr. Nazra.
Thank you, thank you. Thanks very much for the presentation. George Nasra, psychiatrist. I have a couple questions. I'll start with one. Can you say a little bit more about how you think about addressing the health-related social needs for your patients? Transportation, housing. You mentioned East House in one of your cases, but a little bit more in terms of how you are screening for those needs and addressing them. Thanks.
In terms of like the transportation piece and kind of, connecting them to resources, we do really try and link patients with our health home care managers just for assistance, like with transportation, linking them to community agencies if needed. We, working with East House, DePaul, residentials. But yeah, I would say that we're, really trying to get them connected with care managers, getting them connected with PCPs, and other medical needs they might have.
Great. We have one online question that's been posed by Rick or Richard. What percentage of participants have co-occurring substance use disorders in the Community Ties program, even if you seat of the pants guess?
Yeah, I would say the majority, probably at least 75%. Some with varying levels of severity.
And that coincides with what we see on the ACT and FACT programs as well. And sometimes, I think originally with our first ACT program, our model program, it was upwards of 85% of people had co-occurring disorders that were entered into our program. Someone walking up to the mic?
Yes, hello. My name's Lindsay. I'm part of the crisis team inpatient. This was really exciting. Thank you so much for presenting all of this. It's really neat to see the way all the greater teams work together. Very cool. I'm very excited to see qualitative data in the future for outcome measures. That would be just, people taking their injectables, that's huge. Showing up to appointments, like, for sure. But hearing some of their anecdotal experiences would be really cool. A couple questions. One, you mentioned that the program has grown from about 300, sorry, I'm a little nervous because I haven't been in an auditorium for a while, 300 people to about 2,000. And I'm wondering what would be the number in the community of people with unmet services that, given a limited number of you guys, you could meet? You know what I mean? Like, if there's 2,000 people using the services now, how many thousands aren't using the services that need them? I'm very curious to know about that. You mentioned therapist burnout. I wondered what number of appointments are therapists seeing? Like, how many clients a day? Because I think that's just a really important number to know for burnout. And then lastly, feel free to just pick a question. I'm sorry, I'm rambling. Lastly, how does this model of integrating ACT with the other services, does it differ quite a lot from other, say, cities or models? Do you know what I mean? You know what I'm asking? The way that all the programs work together?
I mean, I might be able to address the first two
Sorry.
based on where we are currently with individuals who are waiting on referrals to Strong Ties just because of difficulties with access and staffing and various issues. We can range anywhere from having a waiting list of, we've gotten it down to almost zero, to having 50 or more people waiting for services. Typically, those are from the community waiting. We don't keep priority access appointments waiting. They come to us regardless. But I believe that number would be likely significantly higher. They're just not reaching us to request appointments. In terms of how many appointments are therapists seeing a day, our therapists can be scheduled anywhere from 6 to 8 appointments a day. They are typically back-to-back appointments. We also, given the acuity of our patients, we do have treatment team meetings on a daily basis with our team. So in many respects, that is part of the patient's clinical care, maybe not direct contact with the patient. But when you think about that, there's very limited time that is not just scheduled patient care time or treatment team meeting time. So.
Thank you so much.
Sure.
Thank you. The couple online questions I'll refer to. Helen Vanderland has asked, how many of these patients have identified social determinants of health concerns, and how are these being addressed?
Yeah, I mean, I would say the majority and probably nearly all of our patients have kind of either some sort of disadvantaged or minoritized status that affects their living, their well-being, and that's why we've kind of framed our treatment as within broader psychosocial interventions, mainly care management. We work very closely with our care managers addressing issues of housing, applying for benefits. We have food pantry program within the clinic. We actually routinely on Community Ties bring food to patients that have an identified need. So we have kind of general screenings for those issues that we try our best to meet. Forgetting anything.
Thank you. Dr. Myra Mathis asks, what types of medications for substance use disorders are being prescribed in Community Ties, if so?
That's a good question. We are about to start prescribing naltrexone. We have not had patients with the need for substance use disorder medications identified up until now, but we have a prospective.
Great, so more to come.
Yes.
I just have a question, which I think about in operations, and what does Community Ties need to support your success with clients that are being referred to you? What do you need to hear? What are some things that can support the service or promote the service?
I think the big thing that will be important for us is more substance use disorder, dedicated substance disorder treatment within the team. we are really optimistic about having that in the near future. Nearly all of our patients have co-occurring disorders. I think that'll be critical to be able to deliver those services directly instead of having to link patients to those services elsewhere, because we already know that they have identified other things that.
Anything about from the referring agent, whether it's an ACT team or clinic coming up, outside entities referring, that would help?
Yeah, I think we've been fortunate to have the ACT teams working very closely with us in our team meetings to talk about what the transition may look like and historically what has been a challenge for the patient. So I think data that clarifies what barriers have been or what barriers are anticipated will help us kind of get the ball rolling in the right direction initially. We have a better sense of who the patient is and what's prevented past attempts for engagement.
So that ongoing communication will be essential here. Sarah Mohan from our ACT team has asked, she appreciated the presentation. Thanks so much for the info. She wanted to know if the PowerPoint will be shared.
I assume so.
It looks like we have about a minute or two left. I've got one more question if it's useful. In ACT, we often encounter clients who are not interested in our service. And if thus far, have you encountered that where people have refused your encounters, often because people are referred to you? Maybe they've been challenged to get services, and how have you managed that if so?
Yeah, for sure. I think, we've been fortunate that many of our initial referrals were quite motivated for this. However, we have some that are kind of lukewarm on treatment. And I think they do benefit from having this consistent team that they can get to know even through the initial appointments that is more flexible. And I think the flexibility is the key. So especially patients stepping down from ACT, kind of frustrated with needing to have certain contacts, we can work around that and really focus on whatever is important to them in treatment, even if that means not seeing us very often.
Yeah, I think one of the ways we've also tried to think about our program is basically a clinic without walls. So really being able to, take again those folks who maybe are not excited about treatment, but at least willing to have those visits and just meeting them where they're at. Not trying to force services on them that they're not interested in, and really just trying to understand what is it that they hope for in their life and how can we promote that recovery.
And I think we have time for one more. We have an online question from Terrence James. How would this program assist AOT care coordinators with clients who are in need of higher level of care, and what is the referral process? I don't know if we went over that, but maybe just specifically to that.
Sure. For the individuals with AOT care management or care management in general, my suggestion always is if the patient is already engaged at Strong Ties, to talk with the clinical team. The clinical team can work directly with those community providers to make a determination about that appropriateness for that level of care. If they're an individual who is not currently linked to services through Health Home or even AOT, Strong Ties can certainly be considered as a referral option, and we would ask you to just contact the intake and access coordinator to explore whether Community Ties is an appropriate option. Maria, Romano, and I will review those referrals and make a determination.
Thanks, Pam. So I think we'll conclude. Just a reminder to scan the QR code so you can give feedback and get credit for today's Romano Rounds presentation. I want to thank all of the panelists today for presenting a very important intervention here. We look forward for more outcomes, and I think there's food for write-up here. There's so much information and need about programs like this. So thanks again.